Well, good afternoon. My name is Vanessa Lopez. I'm the Executive Director of Salud por Derecho, an advocacy NGO defending the right to health based in Spain. And thank you to everyone for joining us for this event named Is Universal Health Possible in Europe? Well, as you know, Europe is still a place where undocumented migrants face too many barriers to access healthcare, a situation that has probably worsened during the COVID-19 crisis, with health systems across the continent stretched to their limits. The pandemic touches many lessons, but there are two very essential ones: the need for a real universal health coverage and the importance of strong public health systems. But what does universal healthcare mean? It is feasible. What barriers do people face in different countries? How can we make the necessary reforms? And what is the role of governments and civil society? To talk about all this and much more, we are very pleased to organize this event and to come with colleagues from many countries in Europe. And well, thank you very much for accepting the invitation. We are going to, well, sorry, because I have to make a notice. The event is going to be in English, but in order to understand, well, you have to choose the below the main screen. There is the interpretation button. You have to choose English in order to follow up the seminar. And um, and well, we are going to start with a keynote from Javier Padilla, who is a community doctor with a background and experience in public health, who will offer a context introduction about what is and wasn't universal health and why this is necessary and beneficial for our countries. After his keynote, we are going to talk about the situation on access to health for undocumented migrants in Europe, mainly in France, Italy, Portugal, and Spain. And then we are going to finalize with a Q&A and a discussion. So, please, Javier, the floor is yours.
Thank you very much, and thank you for the invitation. I'm going to share my screen because I've prepared a brief presentation just in order to make easier to follow the keynote. I think it's okay right now. So, well, we're going to talk about what does universal health mean and why do we need it in our countries. The first one, we will talk what does it mean. Afterwards, we will talk about why do we need universal health systems. Afterwards, some brief sentences about Europe, not the situation currently, but what's happened with universal health coverage in Europe in the last decades. And afterwards, to finish, some aspects related to things to keep in mind when building universal health coverage in our health systems. So the first thing is that when we talk about universality and universal health, and many people that oppose to this concept says that universal does not mean for the entire universe. This is something that we have been listening to in Spain many times in the last decade. But well, it's obvious that universal does not mean for the entire universe. But then what does it mean? According to World Health Organization, universal health coverage implies that all people and communities can use the health promotion, prevention, cure, rehabilitation, and palliative services they need, with sufficient quality to be effective, ensuring that the use of these services does not expose the user to financial difficulties. So we can say that when we talk about universal, we are talking about the delimitation, the geographical delimitation. It can be the nation, the state, or mainly the community. But we are also talking about what's inside the concept of universal health. So health promotion, prevention, cure, rehabilitation, palliative care, but also that this care has to be quality, has to have the enough quality to be effective, and it should apply in order to get the function of the health service to protect population for financial difficulties. Okay, so when talking about universal health, we should not reject any of these aspects. The other thing that is relevant is talking about the importance of what, for whom, and how. When talking about political philosophy of health, it's very common to talk about the theories of justice. Theories of justice are composed by three main aspects called the what, the for whom, and the how. So what's included in our universal healthcare catalog in order for universal health to be a social justice promotion? For whom is it going to be? So who is going to be entitled for the right to have a universal health access? And how are we going to deliver the coverage? Regarding the first aspect, we are very used to talk about universal healthcare only related to care, to clinical care. Sometimes we also include prevention and public health issues, but we should also talk about what's happening with the universality of the social determinants of health. So it's okay that we are fighting towards having the universal healthcare in order to get all the population having access to clinical care, but it's also important to have a place for to keep in mind that social determinants of health should be also included in a vision of universal health that includes the social determinants. I'm talking about energy, income, education work. For instance, this week has been released a publication about the mental health effects of the universal basic income experiment in California, that stated that, well, the results that were already expected, that universal basic income had positive results on the mental health in population when it was applied. So social determinants of health should be also included in our purpose or in our aims of universal health. For whom is it going to be is the other important point, because many different people can call universal to things very different to universal. I'm talking especially about those systems that aim to give access only to legalize, only to citizen people, to people who have the right to have the rights. So as Vanessa said, there are many countries where undocumented migrants are currently having real problems that are currently excluded from healthcare. So it's for whom is a very relevant question. And the last one is, how are we going to deliver the coverage? So how are we deciding who is going to have access? Some countries are relating the access to what it's called the workfare. So having a job is the key to having access to this right. But some other countries, and Spain was used to be one of those, have the we can say any person living in the country should have the right to have it. So it's not the job, it's not having a job, the thing that legalizes the access to health. Why do we need a universal health system? Well, there are three main aspects, one related to health, one related to economics, and the other one to politics. In fact, there are no, we can call it rational, there are not rational motives to exclude population from our health system's coverage. So according to health aspects, the systems with universal health coverage have been proved to have a higher life expectancy, lower infant mortality, and also we know that not also including population is better for health, but excluding population is worse for health. So we know, and in Spain it's being studied, that the law that in Spain in 2012 excluded some undocumented migrants from healthcare had the result of 70 undocumented migrants dying every year. So exclusion has the result of higher mortality and higher morbidity. We also know that there are some economic aspects. It's proved that there's a fiscal dimension. We can say that universal health is acting like a fiscal multiplier in a way that the public health investment under universal health coverage models is acting like a motor for, like a way of giving positive feedback in the economic growth. So it has a positive dimension in economic aspects, but also we know that having a broad and inclusive model of coverage to health may take our system to function in a more efficient way, in a way that it's going to give the care in the place where it needs to be delivered. So if we only give the undocumented migrants the right to go to emergency rooms, for instance, they are going to seek for assistance that it should be given in primary care. It's going to be sought in emergency room, that it's quite less effective, less safe, but also less efficient. And in the last term, the political aspects. We know that universal health systems are working for society that are more, it has more social cohesion, and it's related to the, well, we can read much more about Richard Wilkinson and Pickett, talking about how more unequal countries tend to have more unequal health and poorer health, not only for the worse off, but also for the better off. There's a paper published some years ago of Michael Marmot called "Why Should the Rich Care About the Health of the Poor?" So universal health systems are good not only for people who are currently excluded, but also for people who are also the insiders in these systems. This third point about Europe and universal health coverage in the last decade, just some points. Talking about some backgrounds, after the Second World War, there was a big role of the states in health protection. It was moved by a couple of motives. The first one, the need of having a healthy workforce in order to maintain the growth of our productivity, but also the need to keep our savings low, in a way that societies could go on with the promotion of consumption. Afterwards, in the decade of 90s, the boom of the welfare state, it was linked to an increase in health coverage all around Europe. But when in the late 20s and the 2000 and 2010s, the economic crisis arrived, some countries faced this economic crisis with an stagnation in the increase of health coverage that had the conclusion in some countries of exclusion of some of the population groups, generally the worst off. But now we are in a situation that, in my opinion, is really interesting, because universal health coverage was really relevant before the COVID, but now we cannot face a post-COVID society with no universal health coverage systems. In my opinion, there are two key elements that have arrived, having much force in the last months inside the pandemics. They are the interdependence and the need of security. Interdependence understood that this sentence of no one is safe until everyone is safe, although some are safer than others, it's obvious. But this idea that we need everyone safe in order to promote collective growth is important, and the concept of security, of safety, understood as the protection from the unexpected. It's also very important. I think the only concept in public health policies that can have a result of adding interdependence plus security is universal health coverage. So just to finish, just some points I think we have to keep in mind in order to think about our universal health coverage in the future. The first one, it's not just the right to health, it's also the access to the coverage we are going to give. So it's not the entitlement. We have to make sure people is going to be able to jump over the barriers, the formal and the informal ones, to get the access to get the care they need. The second one is that we should think about concepts of and operative concepts of universal healthcare really inclusive. We cannot think about those one excluding pharmaceutical issues, excluding public health issues, excluding community health issues. The third one is related to the importance of making everything easy. That's the title of an article published in Current Affairs a couple of years ago, I think, and talks about that bureaucratic barriers may be even bigger than legal barriers in some aspects. So we should enroll vulnerable population in order to see how we can design our universal health coverage systems in order to make them able to get in there. The fourth one, the need to protect the universal health system for the next crisis, where some governments can have the temptation to dismantle it. And the last thing is that universal health system should be built from bottom to the top. I mean, from public health and primary health care to hospital care. And in addition, it should be seen from a universal health in all policies perspective, regarding the thing I commented before about the need to include the social determinants of health in our universal health coverage perspective. So nothing else. Thank you very much for the invitation.
Thank you very much, Javier, for the great intervention. Now we are going to dedicate 1 hour to review the situation in some countries, some European countries. We are going to start with France, with Agnès Guilino, General Coordinator of Medicines du Monde in France. After her, we are going to have Francesco Aureli, Director of Sanità di Frontiera Onlus from Italy. Sanità di Frontiera operates at the particular benefit of the health of the most vulnerable groups, such as minors, women, migrants, and the most deprived people in Italy and worldwide. And they carry out this work through specific projects and training and research. After Francesco, we'll have Carla Paiva, Executive Director of Médicos del Mundo, Portugal. Well, I'm not explaining who is MDM because everybody knows them. And finally, we are going to have Rocío García Gutiérrez Gómez from REDER in Spain. She is representing this network where Salud por Derecho is taking part as well as part of the core group. And she is a specialist in family and community medicines, and she's going to explain more in detail the situation in Spain that previously Javier has introduced. So please, Agnès, the floor is yours.
Okay, thank you. Je vais ensuite parler.
Okay, now I am going to speak in French, because as many French people, I understand English and I can speak it, but not well enough to give a good enough presentation.
To refresh, for for the people that has joined later, that people should choose the English interpretation. The bottom is below the main screen. Thank you. Sorry, Agnes.
So, okay, it's okay now. I can. Yeah.
Yeah.
Thank you. Donc, je disais que j'allais faire.
I was saying I was going to give my presentation in French because it's much easier for me, but I can do the Q&A in English, I think. I'll try. Okay, so in order to talk about the situation of the irregular, undocumented migrants in France, I ought to speak about the French system a little bit. We have a social security system founded on the principle of solidarity. So each person pays according to his or her means and receives according to his or her needs, basically. So it is an almost universal system. And there are certain exclusions. It is not fully universal. Let me explain how and why, explaining a little bit the workings of the system, which is everything administrative in France is fairly complicated. Okay, so there is the health coverage for everybody, French people and people who are documented residents. That's the social security system, basically. And it is funded by the contributions of working people. And this is, like I said, for French people and French residents with a regular in order situation in France. And there are supplementary insurance for people who are poor, the poorest, for those who make less than 750 euros per month, per person. So the regulated fees for Social Security take basically 86%, and that supplementary insurance would cover for the remaining 14%, reaching the 100% coverage. Now, for people without a permit for residence, there is a specific system or scheme, which is the state medical aid, the AME in French, that's acronym in French. Our system in France is not universal because there is a universal coverage, but it's not the same for one and the other. And there are certain people still who do not have certain rights, don't have rights to neither of these two systems I just explained. And they only have access to a very urgent, vital, we could call healthcare. So in terms of the care or the treatment of, it could similarly appear to be very complicated, particularly because there is, on the one hand, the public service, which is hospitals, basically, where there are regulated rates, and the Social Security takes care of the costs and other health insurance, as I just explained. And there's also the private sector, all the private clinics, all the liberal professionals, where the rates are free. It's a free market, basically. This doesn't mean, therefore, that Social Security takes on everything or just the regulated quantities. But there are certain limits, and if we go beyond those limits, you need either a supplementary insurance or a private insurance. And now I want to explain more specifically what happens with the people who are undocumented, migrants, people who are in France in some kind of irregular administrative situation. In order to have access to this state medical aid, they have to be living in France for at least 3 months and have an income for one person below 753 euros per month. So when we consider our health insurance system, pretty much everybody, with the exception of tourists, should be able to have the right and the access to care. Now, insurance for people in irregular situation covers all healthcare from the minute where they are taken into the system and going by the regulated tariffs. But there are exclusions, as I mentioned, and let me explain. For instance, in 2019, Médecins du Monde received 23,000 requests or dealt with 23,000 cases of exclusion. Why these exclusions? Well, first of all, it's a conditional aid. This aid, it is for people in an irregular or undocumented situation, and you have to prove you are in that situation. Therefore, you have to provide proof that you've been living in the country for at least 3 months, which is already complicated. Beyond that, the situation is truly irregular. So somebody who's come into the country with a visa for 3 months ought to wait 3 additional months if this person decides to stay without any kind of document in order to be able to submit the demand for this state aid. So 3 months with a visa plus 3 months in a regular situation before they can submit their request. Now, you have to have a mailing address, which is difficult for people in an irregular situation, obviously. And there are also organizations in charge of providing mailing addresses for people who do not have one, but these organizations again request you provide proof of not having an address or an accommodation for at least 3 months. So there is administrative barriers, basically, is what I'm getting out. Beyond that, there are certain issues around the time limits. According to the law, the time limit, once the request has been submitted, is maximum 2 months, but we see that it tends to take much longer. It could take 6 months, 7 months before, after having presented this request for state aid, it is granted to the person who qualifies for it. So every year, this is renovated on top of it. And many people we see end up receiving or being granted the aid after. And so in the end, it expires 2-3 weeks, and then they have to start all over again for the following year. So even if you qualify, it can be very difficult, quite a riddle in administrative terms. Another issue is access to information. In order to request a specific health insurance coverage for undocumented migrants, obviously you need to know it exists, and it's very scarcely given, this information, by public or private organizations, particularly by public organizations. Then there is the language barrier, of course. There aren't translators, very few, rather, in public services. And so even if people speak English, not so many people or not so many civil servants speak English, so there is a major language barrier. Even when people get this state aid in the end, some professionals refuse to treat them, even in the public hospitals and care centers. And the explanation would be flat out xenophobic attitudes, in a sense, by some people, this perception that treating undocumented migrants costs a lot. Plus, there is an admin barrier also, because these people do not have the credit card or the means to be able to be invoiced automatically in digital ways, such as for everybody else. It's more complicated than this, but basically, if you do have a credit card or a debit card, you can be invoiced easily in the system. If not, it becomes complicated, and then that's where the problem lies also. Then there is a barrier with regards to access to coverage, very obvious one, which is digitization, and particularly so in pandemic times. After the pandemic, everything's done on the internet. Everybody, obviously without accommodation and without papers, struggle to have access to internet too. And this specific healthcare coverage, this state aid, does not allow for people to have an internet account within the social security system. So it becomes really complicated because they can't have an email account. So basically, they need to do all the admin on the internet, and they don't have access to internet. It's a no-goer. There's also another barrier, which is the complexity of the system. Now, with COVID, okay, I need to speed up. We've had, however, some positive events taking place. Because for COVID, there's been universal coverage and everybody's been looked after, even the most excluded, which were the ones that were most exposed to COVID, particularly. So for this, yes, it's worked. It continues to be a fully universal coverage for tests and for care in the case of COVID. So let me conclude by saying that in the end, the French system, if we consider the legislation, is well designed. But obviously, there's a difference between the theory of the law and what happens in reality. There's also a political evolution that's fairly troubling in a sense, and it's a cause for concern because there's voices that, contrary to what used to happen, which is that healthcare coverage was sacred almost, now people are beginning to not treat it as such a sacred issue, but rather talking about the economics of it. And there's this political discourse about irregular migrants who come and as an invasion, quote unquote. And there is truly now a questioning of this access to healthcare for these people, even though they only equate this healthcare provided to these people 1% of the total. And each year, let me finish by saying this, we see that this coverage exists and continues to exist, and that is good, but it's shrinking every day in small ways, in small details. And so, Médecins du Monde in France, we are always fighting for a universal coverage, but we get the impression that right now we are fighting more than anything else to preserve what exists rather than to add anything new.
Thank you very much, Agnes. Well, now, before going to Francesco's intervention, I have to say that please write down your comments and questions for the third part of the event on the chat, and then we will collect and to formulate the questions to the panelists. Well, thank you, Agnes and Francesco. The floor is yours to explain us the situation in Italy.
Hi, can you hear me?
Yes, perfectly.
Yes? Good. So thanks for this opportunity. Thanks for inviting and for organizing this. And it's actually a pleasure to confront and to understand also what's going on elsewhere. And listening to what Médecins du Monde in France was telling us, I can see that there are a lot of similarities between France and Italy. And of course, I mean, we do in theory and in paper formally have let's say a kind of universal health coverage guaranteed in Italy. And for everyone, actually, from our constitution, article number 32, we actually, every single individual, not citizen, but individual in Italy has the right to health and should have access to at least essential health services. But then the reality is a bit different, and it is different not only for foreigners, not only for undocumented people, even Italians, and not only for European that are living in a vulnerable situation in Italy. It is actually what Amartya Sen was telling is happening when you in a system have a human rights that is guaranteed, but then it is not provided by the entity that guarantees that human rights. So we do have a problem of access. We do have a problem that actually, as I was saying before, has a lot of difficulties that are similar to the one that we can find in France. We have cultural barriers, we have administrative barriers, of course, linguistic barriers. We have barriers that are coming from the information technology, but especially from the general information about the law. And this is not only for the foreigners. In this case, we're talking about them, or for the most poor people. Sometimes the knowledge and the information, there is a lack of that also from the side of the doctor and from the side of the worker, social or health worker, that is. So we actually foresee different kind of aspects. First of all, I think we can talk about the difficulties that a foreigner has in the access due to cultural and linguistical obstacles. And these sometimes are also coming, as I was saying before, from the worker, both the health worker or the doctor himself, or the social worker, because there is a lack of knowledge of the culture of the country of origin from which the person is coming, and that means a lot in terms of cultural barriers that can happen. Linguistic obstacles, because the doctor or the worker do not know even basic foreign language, let's say even English sometimes. So there is a very difficult possibility to interact. And then of course, there is many times the absence of cultural mediators, which are very, very important in our system to interact with foreigners. Sometimes even in health centers that are in the proximities of where foreigners community live, you don't have cultural mediators. And then the doctor many times has difficulties in diagnosing the disease and understanding what the patient is saying. So linguistic and cultural barriers are very, very important. And this, of course, is also on the side of the patient, who do not know actually the language, the culture, and it's not only about the language and the culture, but it's many times also knowing which are exactly your rights, and so knowing that you have the right to health, you have the right to essential services. There is a need of sensitization, of promotion of the law and the rights that every single individual has. For example, foreigners who are undocumented, irregular foreigners, they do. Sorry, I do have a problem with my battery, but I hope that is working. So irregular minors, for irregular migrants, they do have the right to what is called in Italy STP, which is a permit, a small document that is called temporary present foreigners. And with that document, they do have access to ambulatories, clinical centers, health centers, so to the essential services. But they do not know that. And sometimes even the worker, the health worker or the doctor do not know that. And so you have to really work very well, letting know the communities, foreigner communities, that they do have the right to health, they do have the right to this permit, and that they can actually access to the services without any fear to be denounced or to be actually identified as an irregular. This is very, very actually actual, especially now with the COVID. And but it's a big problem that we do have, and we have had for many years actually. Of course, there are difficulties that are related also to administrative knowledge from the operators, the workers, and from the migrants. And these are related to the status that you have, even if you are not irregular. And sometimes you have a type of permits and status that recognize you even more rights, not just essential services, but you do not have know that, or you do not know that you can take the residence, and with that you can have a certain type of access to the services. And that is something that many times not even the administrative worker knows. Then the problem that are specifically bureaucratics, like, for example, the absence of a social security number or a tax code, or the absence of a domicile or a residence, which are not needed for essential services, but the migrant doesn't know that, and many times the administrative worker doesn't know that you don't need that. And so, I mean, we do work a lot also to try to sensitize and to inform and to promote this knowledge, even when with the health workers and the doctors. For example, but we're not the only one. I mean, there are many organizations in Italy, we do have training courses for doctors, psychologists, not just to identify which are the cultural barriers and the psychological barriers that a doctor or health workers many times have to face, but also to understand which are the administrative and bureaucratic barriers, and to inform and to share the knowledge about what is allowed and what is not. Of course, there are difficulties that are coming also from the fact that we have our health system, our national health system is very fragmented because it's given to the governance of the region. We have 21 regions in Italy. 21 regions who have administrative structures which are different from one to another. So there are national rights, and so the right to health is recognized at the national level. This permit that I was talking about, for example, is recognized at the national level. But then administratively and bureaucratically, the region have different rules, different approach, and sometimes even different cultural knowledge and feasibility. So the usability and the fruition of the service, the way the services are provided, the organizational aspects of the service are sometimes also obstacles for the most vulnerables, and sometimes also the hours when you can access a health service, a health center, the gender of the doctor, for example, because for some culture, the gender of the doctor is a barrier, I mean, the low possibility of access, which is not guaranteed by all these obstacles, are a big problem to really see the rights to health provided and recognized, not only recognized. So the work that we try to do is to really inform, sensitize, let the most vulnerable know that they do have the right to get permits that allow them to access health services, that they do have the right to get a domicile, that they do have the right to, even if they don't have a social security number, to access to the hospitals and to the public centers, health centers, and then to inform also the doctors to really, I mean, overcome all these obstacles. So sometimes we do have also obstacles that are coming from technology. I mean, IT systems that do not work, and difficulties to access to the cell phone, which is something that almost every migrant and foreigners in our country has. Difficulties to have access to a computer, and sometimes you do not have the possibility to get the ticket exemption, and you do not have the possibility to access the payment exemption that you have the right to, because you have to go to a computer, you have to go to an app, which many times doesn't work. And then, of course, I mean, the pure quality of the service that sometimes they have to get because they do not have real access to normal hospitals or big hospitals because of where they live. So these are more or less the barriers that we face, and these barriers are causing a lot of difficulties, especially for minors and women. Women, for example, who do have the need of a continuum of care, do have the need of access when they're pregnant, and they get into the hospital just when they have to deliver, without having, for example, a previous visit to any doctor, or without having the possibility or the knowledge that they could have also post-visit to gynecologist. I saw that I have to quit because of the time, so I finish here, but these are more or less all the obstacles that we're facing, as I can see are also some of the obstacles that you have in France.
Thank you very much, Francesco. Yes, actually, some of the barriers you mentioned, both you and Agnes, we are facing the same in Spain, no? Regarding the differences among regions and how the law and the papers, no, the policy papers say something very different to reality and so on. Yeah. Well, now I'm going to give the floor to Carla from the MDM Portugal. Thank you, Carla.
Hi, everyone. So first of all, I want to say hi to all the panelists and everyone who has joined us virtually to discuss this topic of the right of health and share with everyone the situation between the right and the effective access to health. Very shortly, MDM has been working from 15 years with migrants, and as a network, we are always fighting for the guarantee of the universal health coverage. Most of the points that I'm going to talk, most of the speakers already talk about them, and most of the barriers, so I think I try to not repeat and be effective on my intervention. So particularly in Portugal, with the pandemic situation, the protection of the health of migrants and their access to healthcare was reinforced as a human right and a basic right in accordance with the constitutional values and principles, vital for the integration of migrants and a critical factor of the reduction of poverty and social inequalities for the public health and well-being of all. The concept and importance of the intervention of public health in a universe as small as Portugal, with 400 public health professionals, so you can see how small we are, has reached its peak on this pandemic situation. The concept and importance was very important. In the context of the pandemic, many facilitation processes have been created and released. Some of them were released, were taking too much time, and with the pandemic situation, they were released so that the migrants have effective access to healthcare guaranteed. Was decreed that administrative barriers to access to the system of the healthcare system are not allowed, legitimizing that migrants and refugees, regardless their status, couldn't be barriered to the access to healthcare. Leading to believe that the social determinant could be one of the main barriers to the access healthcare. This is what this administrative decree should transmit to everyone, that regardless the situation, that situation couldn't be itself a barrier to the access to the healthcare. Right now we have a lot of documents and referential documents and guidelines to decrease the barrier to health access of the migrants and people on undocumented situation, and provisional refugee situations were denied. So right now the refugee have administrative situation that is benefiting the access to healthcare. Some challenges are remained, and the language barrier is one of them. Everyone has already spoke about this barrier, administrative barriers, bureaucratic barriers, the lack of information, education, and communication in the administrative service, but also for the migrants themselves. Sometimes they don't even know what kind of right they have, what process they need to start to have this access. And as Javier Padilla has already mentioned, one of the challenges is not only having rights, but have the effective access to the health. And the post-COVID should be really, we should be worried about the post-COVID access to health. Not right now. We should learn about a lot of things that we have been working on our own countries, and with a lot of countries' effort. So this is one of the most worry that we should maintain right now. All the results achieved in this pandemic period must be maintained and improved with monitoring and evaluation the process. And we should prepare our system to rupture situations. In pandemic situations, we should learn what I've been working for these 12 years. The administrative and the legal and economic process cannot be a barrier to the access to the healthcare. And that was one of the things that we have learned during these 12 months. If these three structures maintain, public health couldn't find them, because lack of information from the administrative structures, it's bigger than the information that the health professional they have. Sometimes you have a doctor who want to provide healthcare, but himself is stopped by the legal and administrative process. So one of the things is what Javier says, and Agnes and Francesco says, is what will happen after post-COVID. Do we learn anything on 12 months, or do we gonna forget that public health and access to healthcare should be considered as an effective access, not just a right? So I try to be concise and assertive, because everyone before me already spoke a lot of some issues, and they are the same in all countries, despite the size and the complexity of our health systems. Thank you for everyone.
Thank you very much, Carla. Well, we are going to now to explore the situation in Spain with Rocío, who is part of SENFIC, the family. Sorry, I'm going to say, trying to translate to Spanish Society of Family and Community Medicine, who is part of REDER, and in this case, Rocío is going to speak on behalf of REDER. So please, the floor is yours, Rocío.
Thank you. And thank you very much for inviting me, and thank you for this opportunity. I'm going to share my screen too. Let's see. Just a second. No, excuse me. Here. Okay, I'm going to speak about the access to health for undocumented migrants in Spain. Well, the first thing I want to do is
I
speak
cannot
about.
hear actually.
Should I
hear
speak
anything.
louder? Maybe. Can you hear right now?
I can hear you very well, Rocío.
You can or can't?
Yes, I can. Puedo.
Okay. Okay. I'll start again. Well, I wanted to introduce REDER, which is the acronym for the Network for Reporting Violations and Resistance to Royal Decree Law 26/2012, which Javier Padilla already spoke about, and I will speak about a bit deeply. And this is a platform which was established in the year 2013 in order to combat the health exclusion imposed by this law. It's made up of more than 300 social and professional societies in the fields of health, and for example, MDM, Médicos del Mundo, Médecins Sans Frontières, no, Médecins du Monde, SENFIC, the Spanish Association of Family Medicine, or Salud por Derecho, among many others. We have continued working after the law of 2018, which I will speak about too a bit, to achieve the improvement in regulation that guarantee universal health care for people living in Spain. So, well, this is a complicated situation. It's not easy to explain. And even for us, it's a kind of a labyrinth. But I'm going to try to give you some enlightenment in order that you can have an idea of what's going on in Spain in the last years due to these laws I will explain. So the first law is the main law in Spain. Excuse me. I'm going to start from the beginning, is the Spanish Constitution of 1978, which is older than me, but already makes a fundamental right clear, which is in the 43rd article, and is the right to health protection. Before the year 2012, we were in a really good situation in Spain, and the General Health Law of 1986 already was orientated toward universal coverage. And the Public Health Law 33/2011 extended this right to health care to those groups that were excluded. So we were really close to achieve the WHO's strategy for health for all. And we have this other law, which is our star law, the Organic Law for 2000. It's about the rights and freedoms of foreigners in Spain. And the Article 3 speaks about that all the foreigners have the same rights as the Spanish persons according to the universal human rights. Excuse me. And in this law, in the Article 10, foreigners registered in municipal census of the place in which they usually reside have the right of healthcare under the same conditions than Spanish. Those foreigners who are in Spain and have also the right to emergency public health care in the events contracting serious illnesses and accidents, whatever their cause, and also to the continuity of this care until medical discharge. Speaking about vulnerable groups, foreign children under 18 years that were in Spain have the right to healthcare in exactly the same conditions than Spanish, and the same for pregnant women, and also the attention during childbirth and during the postpartum. Nowadays, The situation changed due to this law 2012, who brought very transcendental changes. The citizens were not citizens, they were insured. We didn't have a right, we had a privilege, and only those persons who were able to pay taxes because they were in legal situations had access to assistance. And this exclusion is validated by law. There were some situations that were contemplated by this law, which are for pregnants, which have the same rights during pregnancy, childbirth, and postpartum, with a 40% of discount on medicines, and for passers-by with without resident permit that had the same care but had to pay 100% of the prescription for chronic and public health cases. When 2019 came, we were expecting for some changes of the law, and the title and preambles of this 2018 law was promising universality. It says that the national health system is a human primordial right, and the universal assistance is guaranteed in the same conditions for all the persons. But the truth is that this law doesn't guarantee the right to protection for everyone, nor will it take under the same conditions for everyone. We say that lo llaman universal y no lo es. They call it universal, but it's not universal. The requirements and the procedure to obtain the health care are so hard to obtain, so complicated, and this law does not ensure the assistance to minors, pregnant women, and other vulnerable population groups, or the emergency care. So we are counting that in Spain there are 873,000 persons excluded. Luis Jimeno and colleagues published this paper where they spoke about the number of excluded persons in the community of Aragon, and they could extrapolate it to the rest of Spain. And there's a high amount of people, as you can see. The main illnesses are these that you can see: diabetes, hypertension, dyslipidemia, asthma, etc. Javier Padilla mentioned this paper before, which was published in February 2018 by Juan Martí, López, and Val. And the conclusion is that the estimation of the increased mortality due to this law in undocumented immigrants was the 15%, which corresponds to 70 additional deaths per year in result of this law. We are trying to fight against this law, but we have 5 fundamental problems. The first thing is the existence of, as in Italy, that there are 21. In Spain, we have 17 different regions, 17 autonomous communities with 17 different health coverage and 17 different access requirements, which makes the situation complicated. The barrier registration is the second problem. Most of these communities are requiring 3 months of registration to be able to access to the public health system, when this is something which is not included in the law. In some cities, for example, in Melilla, in the autonomous city of Melilla, the situation is even worse because the access to do the registration starts when the person has already regularized their documents. Then the third problem is the administrative requirements. the accessing to public health system is often impossible to meet. Some people are even asked to return to their countries of origin to obtain some documents, which is obviously impossible for the majority. Speaking about regrouped ascendants, mothers and fathers of those persons who could legally come to Spain, many of them still did not receive a health care, and they are in a vicious circle because they can neither get public nor private care, since due to their chronic diseases, their age, the majority of insurances does not cover them, despite the fact that the justice has agreed with the affected. The exclusion persists. And well, the law does not specify that the most vulnerable will receive care in any circumstances. We're speaking about children under 18 years old, victims of trafficking, pregnant women, asylum seekers, and people who need emergency care. By not making this guarantee explicit, some communities are requiring payments for healthcare to these people when replying to a restrictive interpretation of the rule. And something similar is happening for COVID-19, even though many communities made some exceptionally allowed the care to vulnerable groups and to undocumented foreigners. Is the same case. As it's not explicit in the law, the exclusion is arbitrary and improvised. But well, despite everything I'm saying, I have told, I wanted to have well, first I want to have well, I know we have to be very self-criticism this and we did really bad step backwards since 2012, and we are fighting for zero exclusion. But I would also like to remark that Spanish health system, compared to the most of the countries in the world, is much more inclusive. Well, even though we are still reaching total universality and we didn't cover, we can be a kind of a guide for other countries. Well, that's all. Thank you very much.
Thank you very much, Rocío. Well, thank you for the brilliant interventions from Agnes, well, Javier, of course, Carla, Francesco, and Rocío. Now we are going to start the part of Q&A, but before formulating the questions that we have from the public through the chat, I would like to give the floor for 3 minutes comment to James Mallard from Stop TB Partnership, who asked us to make a short comment about the situation of the TB pandemic in Eastern Europe, and especially among undocumented migrants in these countries. We think it's interesting also to look at concrete disease and geographic area in the region. So James, the floor is yours.
Thank you so much. I've just got a couple of quick slides, but I'll keep it to 3 minutes, I promise. So the first is to say thank you to you all for letting me sort of join and make a couple of quick remarks. One of the things that's been really interesting in a lot of TB high burden contexts has been the connection between key and vulnerable populations, which includes migrants in a significant way, the issue of TB and the issue of universal health coverage. So I note that TB kills 4,000 people every day. And whilst in the EU, TB rates are relatively low, It is very much, as many of you will be aware, a disease associated with inequality. And as economic challenges increase, I guess, in the context of COVID-19, there's probably a need for that increasing awareness of TB. And in particular, I think it's because of, you can note some of the issues in neighboring regions, for example, Eastern Europe in particular, and the Ukraine is one example, where there are significant sort of TB challenges. Equally, in some of the countries where a lot of migrants can sort of originate from, in some of the focus countries of this webinar, and I note countries like Brazil and Mozambique, Sierra Leone, DRC Congo, the Americas, many of which are high burden TB countries, and therefore that TB context is very challenging. I note in the European context as well, this issue of health security, where drug resistance to TB is becoming an increasing problem. And it's something to just be aware of as an additional challenge, and why that conversation with UHC is important. And also the connection between TB and HIV. And in Europe, it's the only region where this is kind of increasing. TB at the global level is very much framed around the UN high-level meeting political declaration. And I note in that declaration, there's particular references around TB key and vulnerable populations, and it includes migrants, refugees, and internally displaced persons as central to that. And as a result, some of the work that we've been doing is conducting assessments, looking at barriers, and they were very much similar to the barriers that the 4 speakers previously have already touched upon. But these, just so that you're aware, are now being documented across a range of TB high burden countries. And costed plans to address these barriers are now being developed. And I note that there's some funding mechanisms at the global level to help take forward this work. And there's some specific projects that are already happening, looking at TB and migration, including in some of the countries really relevant to this discussion. And so the final point that I just wanted to make was that last year, and at the end of the year, a report called The Deadly Divide was released. And it's very much showing this idea of commitments and this idea of reality and the gap between the two. And from the remarks made by all the speakers, I think that this is relevant, not just for TB, but in this broader health agenda for people who are migrants, particularly undocumented migrants. But I note that as a key part of this, there is a discussion very much saying the importance of access to quality and accessible, acceptable and available services, and other people have talked to this already, as part of a TB response. But because of the nature of the disease, in many TB high burden countries, TB is seen as itself as an indicator for universal health coverage, and that might be something to consider in this context here, thinking about migration, migrants, undocumented migrants, and UHC. So I think I'll leave the comments there, and thank you very much for the opportunity to provide the very short intervention.
Thank you very much, James. A pleasure. Well, we have some questions from the public. For instance, the first one is for Agnès. Is it the case that in France, the insured patients pay the cost for medical services and it is afterwards reimbursed by the insurance company? Please clarify.
Thank you for the question, but it's difficult to clarify. In fact, for French people and regular migrant, it's true, but depends on the situation. There is the system says you don't have to pay first. The professional will be paid directly by the insurance. So we have the little card to put in the computer, and the professional can send the note, the bill, directly to the insurance. But it doesn't work, not always. For example, if you go for the hospital, it's always the case. It works always. If you have a big, for the clinic also, if you stay several days, you don't have to pay. But private doctor, GP, often GP and nurse, and not nurse, more GP, first you paid and after you reimbursed. But it's not very high cost. That for French people and regular people. For undocumented migrants, the special assurance they have ensure they don't have to pay. That's the reason why, but first, they have to get it. It takes a long time. And it's a reason why some professionals, some doctors refused to receive them, because they don't, with this insurance, they don't have to pay, but they don't have the card, the special card to put in the computer. The doctor have to be paid. He has to do several steps before, and they don't lie. It's more works for them. So a lot of them refused to receive undocumented people, even if they have this insurance. I don't know if it's clear now. I hope. But the system is very, it's not simple. There is a lot of and if.
Yeah. Thank you, Agnes. Thank you very much. Well, here there is a comment rather than a question, I think. At the end of the road, more vulnerable population like refugees and migrants face similar access problems everywhere. The only difference seems to be the strength of the public system, which might differ according to the country. No? That is. Another question is that can we consider, maybe this question can be answered by, I don't know, Francesca, for instance, or Carla, or Rocío, whoever. Can we consider the administrative condition of not documented migrants as a social determinant of health? If so, why are NGOs not massively demanding a broad process of regularization for undocumented migrants?
Can you repeat the end of the question? Why are not NGOs?
Yeah, why are NGOs not massively demanding a broad process of regularization for undocumented migrants? I mean, Carla was explaining that in the context of the pandemic, the Portuguese government made a regularization process, a very general and very wide regularization process for migrants, undocumented migrants in the country. So this question is really relevant, absolutely. Why not NGOs working on the right to health with migrants specifically? We are not demanding this kind of processes.
Well, in Italy, the situation is not so much the same as that one. I mean, it would be difficult to ask for a regularization because of that, because in reality, undocumented and irregular migrants, they do have the right to health. They should have the right to be, I mean, taken into account and into a proper care also during the COVID. And they should have access to vaccines. So the issue of regularization is a bit delicate. We, for example, Sanità di Frontiera, our organization, is fighting for not post-regularization of migrants, but a real change in the law that welcome migrants, having them regular since the beginning, and not accepting irregular migrants just because we don't want to have migrants besides refugees or migrants who should have the right to be welcomed. I mean, it's a bit delicate. So in Italy, we actually fight, and we have a lot of table where sit a lot of different organizations from MDM, MSF, I mean, many organizations, including us, where we do organize ourselves to advocate for access to all the cure and all the continuum of care that irregular and undocumented migrants should have during this pandemic, including vaccine. So I think it's a bit different from country to country, probably. Yeah.
Mm-hmm.
Yes. Yeah, so if I can add something, yeah. That we cannot compare what happened in Portugal because the Mediterranean flux of migrants and refugees are extremely different between Italy, Greece, and Portugal. So the civil society must understand what is this process. Otherwise, NGOs cannot be supported by the civil society. If I may understand my contribution. So NGOs can't fight by themselves, only by themselves, this change of mindset, because these three countries, at least, they face different realities from migrants and undocumented migrants and refugees realities.
Mm-hmm. Okay.
This is one of my understandings why the Portuguese government just act so quickly, but yeah, for sure was the public health system pressuring the government to have this process, this administrative process done, but for sure Italy need to see this kind of administrative process on with other factors.
Okay, thank you. The rest of the panelists, of the colleagues, want to make any comments on this?
Well, I would like to say that, of course, administrative conditions are social determinants of health, but the fact of being a foreigner is a social determinant of health. The fact of being of poverty is a social determinant of health. So this is summing many determinants. And about the NGOs, well, I think that the NGOs are demanding the process of regularization. That's what Weather and other associations in Spain is trying to do. Of course, it's not easy. Of course, we have to fight against really complicated barriers, but we keep on fighting.
Yep, absolutely. Yep.
I would like to. Oh, okay.
No.
Go on.
Oh.
As you like, Javier. Okay.
Agnes, yes, please.
Just a comment. I think we are demanding a process of regularization, but all the government are deaf, completely deaf. And I think it's always fear about political nationalist. And I think behind this demand, NGO can be a little afraid by the react of all government facing nationalist politics. I think it's a problem also. It's an issue.
Yeah. Javier, yeah.
Yeah, I would like to add that in Spain, I think there are many NGOs that have raised the voice in order to ask for a massive regularization. But I think that there are two things that we have to take into account when talking about this. The first one is that migrant population in general and undocumented migrant particularly have little or no presence in many social movements. as participants. I mean, I think that's capital in order to see undocumented migrants as a political actor in situations like this one, where we are like focusing on median class problems in the context of the pandemics. The other thing is, in Spain, we have not even been able to approve a law that could find a solution for the problem with undocumented migrants in health right now, currently. So it's obvious that, in my opinion, we should strongly support the efforts of NGOs regarding massive regularization, but we should know that the reality, the material reality is the one it is. You know, we have not been able to make our health system actually universal in the context of a pandemic. So I think that these are two topics we should talk about.
Thank you. Well, I have a question for you all. What are the specific demands, the asks that you are, in terms of legislative change, that you are asking in your countries? No? Because, well, I mean, Rocío was explaining, no, the whole process of changing different royal decree and so on, but I would like to ask you about the specific changes, no, the concrete changes at the law that you are asking for in your countries.
From our side, while we are working directly with the public president, is the same that I finish my intervention, is to pick up on the lessons learned, increase them, monitorize them, and learn with the other countries what have been done in the pandemic context, and try to apply them on the normal context, and learn what kind of access to health have all people, but most of them the vulnerable people. So we cannot forget what we have done these 12 months.
Thank you, Carla.
We don't need emergency pressure to learn. It's the point.
Absolutely.
Maybe I can, for France, MGM has an advocacy on several plans. First, the universal coverage, of course. Second, the cost. Not second, it's not in the good order. The cost, medical cost and medication, cost of medication. It's very, I think.
Cost of life.
No, not of life, of medication.
Yeah.
Laboratory, for an example, for the hepatitis B, hepatitis. So, and we fight against care refuse by professional. We denounce it. Now the law has changed. There is a new law against professional who refused people who make discrimination to receive people, but it's a law. That's changed, but maybe one time we can, people can have justice, maybe one time. The law has changed. We fight against social security. I don't know the equivalent in the institution of social security to apply the law In fact, the change of law is universal health. That's the reason why I said we fight to preserve what exists, and for the change is universal health.
Okay, thank you, Agnes. Rocío, Francesco.
Well, I guess that our short-term objective is to derogate these laws, the 2012 and 2018. But I think that the situation of being in the same conditions for immigrants and this person is falling in the inverse care law. So maybe we should give some step forward, and the conditions should be even better for these vulnerable groups that have other kind of problems.
Thank you. Javier?
Sorry.
Francesco, yeah.
Okay.
Wow.
No, I wouldn't actually say that we need to change the law related to health, because as I was saying before, I mean, we do have the right to health recognized in Italy. We do have, I mean, the national system that guarantees, in theory, the access. Is what needs to change are the laws that then give the possibility to see this right provided to everyone, and so what I would say, I mean, I would actually try to change at the level of culture, at the level of sensitization, of promotion of what is needed to overcome those obstacles that we were talking about before, not really laws related to health in reality. This goes not only for undocumented, irregular migrants or foreigners in general, but for vulnerable people, even Italians and other Europeans who live in Italy. So it's a matter of inequalities that can change not through laws but through approaches at the moment, because I would say that the health system in paper, so talking about laws at the moment, should guarantee access and universal health coverage. What I mean, talking about migrants, what should change is the big law that govern the entire system, and so a law that could guarantee that migrants who are not entitled to the status of refugees can enter in the country and can find work and can be integrated. And so that they could see provided all other rights that are related to the determinant of health. So all the other rights that can guarantee also the well-being, which is a fundamental part of health for them. So that's what I see in Italy, actually.
Mm-hmm. Thank you, Francesco. Javier?
Well, actually, what Rocío said about Spain, but I think it's very clear and very relevant what Francesco just said. I think it's important to consider two things. On one hand, the importance on recovering the view of universal health as the addition of different social determinants of health, and migrants are in the worst off part of all those determinants of health. But if we are only looking at the health issue, the healthcare issue, in Spain, it's very important to suppress the differences between migrant and not migrant population, to eliminate the minimum time of 3 months that people should be like resident in Spain in order to guarantee their right to healthcare, and to guarantee the access for the relatives coming from their origin countries to Spain right now. But so I think in Spain we have the advantage that we already had a legislation that was quite close to what we can think about regarding universal health coverage. So the legislative things we should do are like very clear. So the thing is doing it.
Yeah, no, absolutely. And I think that it's worth it to mention that after many, many years of fighting from Reder and other networks in Spain, the Ministry of Health announced in December, if I'm not wrong, that they were going to change the legislation because they openly recognized that the current law still had many barriers, that they didn't succeed into fix it. But this recognition, it was a very difficult milestone to achieve. So we hope that this commitment from the government to fix those administrative aspects at the Spanish law to allow that everybody in Spain has access to healthcare came into reality over this year. I have a question to all of you as well about, I mean, the role of Europe. No, at the end of the day, we are talking about European countries, and the European Union approved or declared or whatever the societal pillar, no, some time ago, and then we have the Universal Health Coverage Declaration made at the UN. So how these elements, no, how these elements could help, no, or is there anything at European level that we could do to make universal health coverage a reality for migrants, for undocumented migrants in Europe? And this is more or less, I want to incorporate other question in this, more or less in this regard, no, regarding how to fight for, how is more efficient to fight for universal health coverage at national level, at regional level, at the international level. I mean, I don't know, it's a quite complex question and not very concrete, but can we do something at the European level and use these kind of international declarations to fulfill the commitments?
Okay, if no one wants to talk. I'm kind of pessimistic about trying to guarantee a universal health coverage from a European level, from top to bottom, by saying, in my opinion, maybe the national level, because different countries have such different systems of health. I think the national level would be the best one, but in the European level, I think that different national levels different countries could take part into what we can call a virtuous competition, in a way that they try to promote universal health system by trying to replicate what they are doing in their own countries. So I think this would be a more effective way than trying to guarantee universal health coverage for the whole Europe. That may be easy to achieve in a legislative way, but in my opinion, it was going to be very difficult to try to organize and to take into the ground in the regional level, especially in the way to define what is considered this universal health coverage. So in my opinion, it's very possible that if we try to achieve a universal European health coverage, what we will get is a minimum universal health coverage in Europe.
Yeah. Thank you. James, you have the floor. Yeah.
Just very quickly to add, and I guess to complement Javier's point, I think with some of these issues, they're obviously very complex and they work across different levels, and maybe at different layers and different levels in response, there can be different interventions for different forms of success. I think in the context of TB and accountability, what we're seeing is clearly it needs to come from the grassroots. That to do that, you need initiatives like community-led monitoring and this sort of thing. In addition, you need, and some of the speakers have touched on this, you know, that multi-sectoral engagement, bringing together some of these different actors to the table to come up with those shared lines of responsibility and to keep people on track. But I also think at that top level, some of these issues do transcend national borders, and migrants is clearly a critical one here. But equally, so do some of the other actors that are involved, like the private sector we haven't really talked so much about, but they have an important role to play in probably realizing UHC, whether it's on terms of the provision of drugs and diagnostics and services, but also in many countries where they're a main source of health provider themselves. So just to note, I think that there's different responsibilities there, and that's why it's really important for these different layers and levels to talk to one another in order to really force through that UHC, and also UHC in the context of human rights for those groups who are most vulnerable and marginalized. Thanks.
Mm-hmm. Okay. So there is another question. Someone asked, what about vaccination, COVID vaccination? Francesco, I think, mentioned that in Italy, undocumented migrants will be vaccinated with the COVID vaccine. In Spain, the announcement from the ministry is the same, but we don't know still how. So what about in the rest of the countries? And also Rocío and Javier, I mean,
sorry, just to clarify, I said that they should be vaccinated. I don't know if they will be vaccinated, migrants, because we are actually advocating a number of organizations, for them to be really taken into account. I mean, it's not just a problem of migrants. I mean, there are other categories that are in the list of those who will be vaccinated, for example, disabled. But then the government, until now at least, didn't really provide the means to ensure that they will be vaccinated. They will be informed, they will be reached out, and they will be vaccinated as the others. But in theory and formally in Italy, for example, older people, including everyone, so including undocumented people, or people who have comorbidities, they are entitled to be vaccinated already, and they should be reached out, and they should be provided with all the means to access this vaccination. So in theory, that's the case, but then we are trying to advocate for this to happen really.
Okay, sorry, because I think I read on La Vanguardia, Spanish media, that Italy was going to vaccinate migrants. So sorry, Javier.
I really hope so. I really hope so.
Okay.
Yeah, in Spain, we can say that certain undocumented migrants are being vaccinated or not, because we have no numbers about it. But there is the ability of the health centers where they are vaccinating, or where we are vaccinating the people over 80, to do an active recruitment of population. So we are, in fact, there is not a list of people over 80 with no access to healthcare that can be vaccinated. But if we know of a person with no access to healthcare that is under the groups of vaccination, the over 80 at this moment, but in some weeks we will be vaccinating the over 70. They can be included in the electronic record in order to vaccinate them. So they are covered, but maybe the way of getting them to be vaccinated is not the best one, and at least in Community of Madrid.
Okay, I understand. Anyone else?
maybe in France. So in France, we don't know exactly for COVID vaccination, how does it work for French people? So it's difficult to know how for migrant people. but normally for others vaccination, when we have enough vaccine for everyone, it's the access to vaccination is unconditional. We can have, everybody can have a vaccine with the document, without document, it's not a problem. For COVID care, it was not a problem, undocumented or documented people. Everybody can get. So if the system keeps this logic for vaccine and COVID, normally undocumented people can have vaccine. But now they are not, it's only people over, also over 80 years old. It's professional care professional, nurse, doctors, and etc., who can be vaccinated. And often undocumented people is young, are young, a group of young people. So now the young in France are not vaccinated, but I think it's a priority, different priority.
Okay. So, well, we have 5 minutes left to close the events, and actually the Zoom platform is going to like disappear at 6 o'clock. So I would like to ask to you all a final remark, 1 minute final remark to close the seminar. So, Agnes, maybe you can start. It's because I have on my full screen. That's the reason.
Only because I have full screen.
It's random. It's a random. Yeah.
So to conclude, thank you very much.
No, yes, one. I mean, one final comment from you, and then from Rocío, Javier, and so on. Yeah.
It seems the same issues in all countries around on the panel, and I don't know if we are to be reassured or we are to be afraid by, but we are not alone with this fight.
Yeah, thank you. Yeah, Rocío, for instance.
Well, I think that there are too many good reasons to achieve universal healthcare for everyone, as Javier could explain to us. And this is something that we have to keep on fighting in the next years. The situation of COVID did the situation more complicated even of what it was before, but we also learned some issues of this pandemic. So I hope that in a few years we will be able to improve the system and to achieve our goals.
Thank you, Rocío. Yeah. Francesco, for instance.
I think that I mean it's very, very important to organize this kind of debate and confront and learn from one another what is going on. But I do share what Javier was saying before. I mean, we should try to work first in our country to then be able to sit at the table of the European Union or at the international level in a different way. And what I can perceive is that we do need a cultural change, very strong cultural change. So it would be very good to have the aim of trying to change at the European level, doing a good job at the local level, at the national level, and then sharing and then organizing, maybe even going beyond this kind of debate, organizing ourselves do advocacy at the European level. So the cultural one is really important.
Yeah. Thank you. Yeah. Carla?
Yeah, so just trying to reinforce what Javier and Francesco just say, that is the universal health coverage start right now with us, with the little debates on our own countries, with our neighbors, our beneficiaries, and start to improve till we are strong enough to deal with the EU.
Thank you. Yeah. Javier?
Yeah, yes, I think that it's very clear that universal health care is a key element for social justice and a key element for the construction of a fair society post-pandemic. So, but it's not only fair, it's also and mainly achievable. So, and also necessary. So I think it can be seen as a main axis in order to develop public policies and social policies in the framework of Europe and also the global one.
Yeah, thank you. Thank you. Well, thank you very much for this debate. I enjoyed a lot, and I would like to, well, to maintain some of the reflections that you have made in these last few remarks. Not there are many NGOs across Europe working on this matter. I think that as Francesco and Carla and Javier suggested, to continue collaborating and making maybe cross-border, EU cross-border collaboration and actions to reinforce our role. I think it could be interesting for the future. I hope that the COVID pandemic means an opportunity to achieve our goals. And well, thank you very much, and thank you very much for the participants. Thank you for joining us, and well, we continue the conversation and the fight. Thank you.
Thank you so much for organizing this.
Thank you.
Bye,
Thank you for the invitation. Bye, everyone. Have a good day.
Thank you.
Bye-bye.
Cheers.
Bye. Bye-bye.